So what we're going to do, since we're a little bit early, we don't want to start the next talk until the proper time in case someone's scheduled to come down here. So what we're going to do is have a panel at this point of the first two speakers, and that's going to be Dr. Clarke and Dr. Ellinwood. And we've got a microphone here, so please raise your hand. We'll bring the mic to you. If you want to say, what you're a parent of or syndrome you're asking, please do so, and direct your questions to them. And I'm going to kick one off since while you're thinking of your questions. I was curious, Matthew, when you talked about the less than 5% correction of the cells, I don't know if I understood you right, but I thought you were saying that the current, the infection of the other cells may be less than 5%, and whether or not that'd be enough for efficacy. Could you expand on that?
My comment was specifically about gene editing technologies like CRISPR, which at this point are not very efficient. So, and I use that 5% simply taking the idea that 5% of normal activity may be the therapeutic threshold we need to treat the enzyme deficiency aspect of these diseases. That level of gene correction by gene editing, CRISPR, base editing, et cetera, we're not at that level yet. We're not at that efficiency yet. That was my comment.
Yep. So that's a particular type of gene therapy as we would think of it, but not overall gene therapy.
Correct. There have been some animal studies that have documented gene therapy leading to enzyme levels that are 100 times normal levels in the animals. So we know that gene therapy can approach carrier or normal or exceed that level of enzyme activity in the plasma and tissue of patients.
Okay, I'm sorry. I have a question about the vectors used. You have to get tested, right, to see if you've been exposed to the viruses before. What happens, I guess, if you're already exposed to the virus, or if when you're tested, I'm sorry, I don't know how to phrase this. How easily are you exposed to the virus? I understand, what are the odds that you get tested for the virus and you're not exposed to it? But then before you actually get to, and then you're retested, you're exposed. I mean, how does that happen?
So these diseases don't cause, or these viruses, AAV viruses, don't cause disease. And they need a double infection, either a herpes viral infection or an adenoviral infection on top of the adeno-associated viral infection of the cells to produce viral particles and for you to be exposed and become immune. I misspoke when I said RH stands for recombinant human. That's for rhesus. It's derived from monkeys. I don't know what I was thinking. So in the case of RhAAV10, they took a AAV that was found in rhesus macaques. We're not likely to have those antibodies, right? For all of the other vectors, they've done screening among the human population and know what percentage of patients may be seropositive or not. And it's not ever a very high number. But you will see an exclusion criteria for clinical trials. You can't have autoantibody, or you can't have antibodies to AAV6, for example, because those antibodies will lead to the vector not being therapeutic or being taken up by cells. Did that touch on most of your questions?
Where do you get the antibodies? How do you get exposed to the antibodies? Because
Someone sneezes in your face who may be having an infection.
that easily, like 1 second you cannot have the antibody, and my child could be eligible for gene therapy, and then the next second it could be taken away just like that.
That's,
Okay, that's just what I wanna
true,
know.
but I also would like to emphasize these are not common. The seroprevalence is low, and most of these seroprevalence studies are being conducted on adults. So, you may have 5% of the population as adults and that's a lifetime risk of exposure, who've encountered that particular AAV. So it is, what you've said is true, but I don't want every family to put their kids in a bubble necessarily.
Yeah, I'm sorry, that was not filtered by the way I said it.
You're fine.
But excellent question and good thinking.
So my name is Christine Yu. So I have a question about the first talk mentioned about the importance of recognizing the symptoms early during the process. So that will get down really about educating physicians to make diagnosis in a timely fashion. Especially, I would think that will have something to do with the primary care physicians. So, are there anything have been done, like say in Canada, or in terms of educating physicians, or what are the things that you think that should be done?
Yes, that's a really excellent question. That it is very clear now that we understand more about the pathogenesis of disease that, like I said, timing is everything. And early initiation, whether it's gene-based therapy or other therapies, is going to be more successful early in the course of disease. So part of that is education of physicians. As you will all understand, that's a very complex phenomenon when it comes to rare diseases. Because you're not trying to target education of geneticists or metabolic specialists. What you're trying to target is the nurse practitioners and the general practitioners who are seeing the early signs. And I bet you almost every single family here can tell us the story of their diagnostic odyssey, of a parent or a grandparent realizing 2 years before a diagnosis, and sometimes 5 or 6 years before a diagnosis, that there is something with that child. This is one of the reasons why there has been a push towards newborn screening, because newborn screening does not require necessarily to wait for symptoms or for a doctor to recognize disease. Primary care doctors now are in a very difficult situation where there's numerous therapies for rare disorders, and for a lot of these rare disorders, most general practitioners will never see one in their entire career. And so there has been a number of studies. There was actually a good study done in the Netherlands by Dr. Frits Weiberg's group, who is a clinician researcher, has been involved in MPS research for a long period of time. And they actually did a study of particularly targeted towards MPS 1, MPS 2, and MPS 3 of age of diagnosis, before and after an intensive education program in the Netherlands for general practitioners. And it was a very depressing study because what it showed was there was minimal impact on age of diagnosis by educating physicians. And again, it just gets to the rarity of the disorders. So there is a lot of education that's going on. A number of the companies involved in development of therapeutics are involved in educational sessions for primary care doctors as well as subspecialists. A number of the companies have also arranged for relatively easy and quick testing of patients. In the American healthcare system, it's a little bit more complex to organize testing for a patient. In Canada, testing is relatively easy to organize. I don't need to have government approval to order testing, but you still need that physician to say, I want a urine mucopolysaccharide screen, or I want an enzyme measured. So in the United States, a number of the companies have now established easy and free access to testing for physicians, but it still requires that physician to request that test. So I think we need to move more towards newborn screening, but I also think we need to perhaps, if newborn screening is not going to be taken up for some of these disorders, that there is a role for targeted screening. Newborn screening tends to be promoted quite actively because it's relatively easy, it's accepted by populations, and it will cover the entire population. But one can also consider doing things like targeted screening. all children who are diagnosed with autism spectrum disorder or early developmental concerns or with any orthopedic issues, one can then use that as the entry point for testing. So there's a lot going on to try to promote that, and I think the National MPS Society also has that role to play as an advocate in teaching healthcare providers. But it's complex.
Hi, my name is Bob Hess. I'm a father of 2 MPS I transplants from the 90s, a while ago. Can you clarify something? And maybe I missed the science, but back then they were talking about stem cells being manipulated to express enzymes. Is that like gone, or has that been morphed in a different area? Is there any hope there, or is that kind of just been replaced by new therapies that you presented? Stem cells manipulating enzymes.
There are 2 protocols now where that's exactly what they're doing. So the hematopoietic stem cell transplantation ex vivo gene therapy being done in Italy for MPS I and being started in Manchester and other sites for MPS IIIA. What they're doing is mobilizing, they're giving patients drugs to get lots of stem cells into the peripheral circulation, purifying those from blood, in a petri dish, exposing them to lentiviral vectors to transduce them, and then infusing them back into the patient. And the brilliant part here is they won't have an immune response to their own cells for the most part, and the idea that we have to knock out their immune system is not an issue. They will require some what we call making space in the bone marrow. I don't think that's the right thing, but they give them some drugs to knock out some of the hematopoietic stem cells to help engraftment of the cells that they've transduced with the lentiviral vector. So what they discussed with you is exactly what's happening, and there are 2 active clinical trials. And also for some of these severe combined immunodeficiencies, those therapies have already been proven effective, that approach. But again, they have the issue of selective advantage of the cells. It's a little easier to treat those than it is our enzyme deficiencies.
I'm just going to add, one of the advantages of that stem cell approach that Matthew was talking about with the lentiviral transduction is you have an ability to now have those stem cells produce 10 to 50 to 100-fold of the enzyme. So it's similar to bone marrow transplantation, except with bone marrow transplantation, that cell is producing only the regular amount of enzyme that cell would produce. And the advantage of these, or the potential advantage of these transduced cells, is the fact that it's the same cell that is responsible for that bone marrow transplant, but it's producing the enzyme at 100-fold. So even though you've heard that it only takes maybe 2 or 3% of the enzyme to correct a cell, the difficulty with a stem cell approach is that's the only cell now in that person's body that is producing the enzyme, so it has to be the source of enzyme for the rest of the tissues. So when it's only producing a very small amount of enzyme, you only get a certain small amount trickle into the other cells that are not producing it. Whereas if that stem cell is now producing 100-fold enzyme, then you may be able to permeate other tissues or have other cells that don't produce the enzyme see more enzyme. That's the theory. It remains to be seen what is going to be the difference in outcome of patients, again, depending upon where a patient is in those cascades I talked about.
That supercharged production of enzyme is particularly important for things like Sanfilippo, where we know from studies done by Ed Wraith that transplantation of kids as early as 6 months of age don't seem to affect clinical benefit. So getting just normal transplanted cells into those patients doesn't work. That's why the hope these supercharged cells massively overexpressing enzyme will.
Hi, I'm Tamara. I'm the mother of, my son has MPS I. Dr. Clarke, you were talking about how there was a lot of similarities with some of the cascading issues with other diseases like Alzheimer's and Tay-Sachs and stuff. So moving forward with kids that have some of the cascading problems, with looking at treatment options or testing them the way you would test for some of those other diseases and providing some of the same treatment options, would that be something worth considering?
Yes, it's definitely an area that has begun to open up. And in fact, when it comes to the bone and joint disease, that is what has been responsible for considering more powerful anti-inflammatory drugs, more powerful drugs that are being used for autoimmune arthritis and inflammatory arthritis and osteoarthritis, which may have a role to play in modulating disease. With respect to the central nervous system disease, that has been attempted in a number of patients where molecules that are known to interfere with ganglioside metabolism as well as cholesterol esterification, and the signal has not been particularly strong. And so although we're seeing those similarities, it's not yet translating to a different approach for therapeutics. But I think we need to now watch all those areas. The similarity between progressive Alzheimer's disease and the mucopolysaccharidoses, we need to keep our eye open of what's going on with respect to those areas, because there may be therapies that come out which may be open for the MPSs.
Okay, we've got time for one more question.
Good afternoon. I'm Warren Wishewski. I'm the Chief Medical Officer for CELOS. Thank you for the nice conversation and discussions, presentations. So Dr. Clarke, if it's not a storage disease, or maybe it's just not a storage disease, what's going to happen with your super stem cells who are replacing enzyme and doing anything else? And I agree with, I'm in the middle. I think the storage has a significant part of the pathophysiology that's involved. I think the lysosomal issue is a major portion of the disease as well. The question is, why does a single enzyme defect lead to lysosomal dysfunction, autophagy dysfunction, and all those other things that are at play here? So if we replace all of the enzyme, we got every cell up to 10%, if the lysosomal portion of the disease, or if the storage is not just the storage, but is part of a surrogate of the marker, why would we replace enzyme?
I'll just get back to timing. It's purely going to be timing. If one could replace the enzyme to 3 or 5% in every cell of the body, and you do it early in the course of disease, you'll have a very powerful effect. But you know, when you think about something like Sanfilippo, where the involvement is primarily in the central nervous system, where the establishment of neuronal pathways, of neuronal connections for learning, of the complex interconnection that is part of the development of the human brain, there's going to be a time threshold by which you could have the best therapy available that could replace the enzyme in every single neuron, but unfortunately you've done it at 15 years of age, or you've done it at 10 years of age. What we don't know is, where is that time window? When is that threshold reached? How much abnormal neuronal circuitry has already now been established in utero because the lysosome has not been functioning normally? We don't really have any ideas. But what I think we need to keep our eye open is a clinical trial may be performed at the wrong time of a very powerful drug that, if applied at a different time, may have a better effect. And so understanding these cascades and understanding that when a hip is already destroyed and out of place and fibrotic, it probably doesn't make one hoot of difference if I could get 1,000-fold enzyme into that joint. The hip is now destroyed, the hip is now abnormal. When did I need to intervene, and at what time? We just don't know yet.
Don't disagree with that. Thank you.
Thank you, Dr. Clarke and Dr. Ellinwood.